This is Chapter 8, Lifts and Carries, and Chapter 10, Methods and Acronyms. Chapter 8, Lifts and Carries. Power lift steps. Step 1. Lock your back into a straight curve. Spread and bend your legs. Grasp the backboard, palms up and just in front of you. Balance and center the weight between your arms. Step 2. Position your feet, straddle the object, and distribute your weight evenly. Lift by straightening your legs, keeping your back locked in. That was power lift steps. Whenever you grasp a stretcher or backboard, your hands should be at least 10 inches apart. True. Lifting by extending the properly placed flexed legs is the most powerful way to lift and is called a power lift. A power grip involves inserting each hand under the handle with the palm facing up and the thumb extending upward. You should never grasp a stretcher or backboard with the hand palms facing down over the handle. Backboards are commonly used for patients who are found laying down. A power grip involves inserting each hand under the handle with the palm facing up and the thumb extending upward. Something got copied and pasted wrong, but I'm just going to read this anyway. Position yourselves facing the patient. The providers at each side turn the head end, hand palm down, and release the other hand. The providers at each side turn toward the foot end. The provider at the foot end turns to face forward. Now a new carry, one-handed carry. Face each other and use both hands. Lift the backboard to carrying height. Last, turn in the direction you will walk and switch to using one hand. Stair chair. Position and secure the patient on the chair with straps. Take your places at the head and foot of the chair. Lower the chair to roll on landings and transfer to the stretcher. Next, moving a patient on stairs with a stretcher. Strap the patient securely. Make sure one strap is tight across the upper torso, under the arms, and secured to the handles to prevent the patient from sliding. Carry a patient downstairs with the foot end first, always keeping the head elevated. Next, loading a wheeled stretcher into an ambulance. Tilt the head of the stretcher upward and place it into the patient compartment with the wheels on the floor and the safety bar latched on the hook. The second EMT on the side of the stretcher releases the undercarriage lock and lifts the undercarriage. Roll the stretcher into the back of the ambulance. Secure the stretcher to the clamps mounted in an ambulance. In a two-person carry, one of the providers must walk backward. Rapid extrication technique. The first provider provides inline manual support of the head and cervical spine. The second provider gives commands, applies a cervical collar, and performs the primary assessment. The second provider supports the torso. The third provider frees the patient's legs from the pedals and moves the legs together without moving the pelvis or spine. The second provider and the third provider rotate the patient as a unit in several short, coordinated moves. The first provider, relieved by the fourth provider as needed, supports the patient's head and neck during rotation. And later steps. The first or fourth provider places the backboard on the seat against the patient's buttocks. Use of a backboard may depend on local protocols. The third provider moves to an effective position for sliding the patient. The second and third providers slide the patient along the backboard in coordinated 8 to 12 inch moves until the patient's hips rest on the backboard. The third provider exits the vehicle, moves to the backboard opposite the second provider, and they continue to slide the patient until the patient is fully on the backboard. Last, the first or fourth provider continues to stabilize the head and neck while the second provider and third provider carry the patient away from the vehicle and onto the prepared stretcher. Direct ground lift. Line up on one side of the patient with one provider at the head, one at the waist, and one at the patient's knees. All providers should be kneeling. Now place the patient's arms on his or her chest if possible. On command, lift the patient to knee level. On command, roll the patient toward your chest and then stand and carry the patient to the stretcher. Next, extremity lift. The patient's hands are crossed over the chest. Grasp the patient's wrists or forearms and pull the patient to a sitting position. Your partner moves to a position between the patient's legs facing in the same direction as the patient and places his or her hands under the knees. Rise to a crouching position. On command, lift and begin to move. Direct carry. Position the stretcher parallel to the bed. Secure the stretcher to prevent movement. Face the patient while standing between the bed and the stretcher. Position your arms under the patient's neck and shoulders. Your partner should position his hands under the patient's knees. Lift the patient from the bed in a smooth, coordinated fashion. Slowly carry the patient to the stretcher. Gently lower the patient onto the stretcher and secure with straps. Last one for Chapter 8, using a scoop stretcher. Adjust the length of the stretcher. Lift the patient slightly and slide the stretcher into place, one side at a time. Lock the stretcher ends together and avoid pinching both the patient and your fingers. Secure the patient to the scoop stretcher and transfer it to the stretcher. Chapter 10, Methods and Acronyms. OPQRST, onset, provocation/palliation, quality, region/radiation, severity, timing. Sample, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading up to the injury or illness. DCAP BTLS, deformities, contusions, abrasions, punctures/penetrations, burns, tenderness, lacerations, and swelling. Performing a rapid exam to identify life threats. There's like 8 here. Assess the head, looking and feeling for DCAP BTLS. Have your partner maintain inline spinal stabilization if indicated. Assess the neck. Assess the chest. Listen to breath sounds on both sides of the chest. Assess the abdomen. Assess the pelvis. If there is no pain, gently compress the pelvis downward and inward to look for tenderness and instability. Assess all 4 extremities. Assess the pulse and motor and sensory function. Assess the patient's back. If the spinal immobilization is indicated, do so with minimal movement to the patient's spine by log rolling the patient in one motion. How to systematically assess the patient. Observe the face. Inspect the area around the eyes and eyelids. Examine the eyes for redness and contact lenses. Check pupil function. Look behind the ears for battle sign. Check the ears for drainage or blood. Observe and palpate the head. Palpate the zygomas. Palpate the maxilla. Check the nose for blood and drainage. Palpate the mandible. Assess the mouth and nose. Check for unusual breath odors. Inspect the neck. Observe for jugular vein distension. Palpate the front and back of the neck. Inspect the chest and observe breathing motion. Gently palpate over the ribs. Listen to anterior breath sounds, mid-axillary and mid-clavicular. Listen to posterior breath sounds, bases and apices. Observe and then palpate the abdomen and pelvis. Gently compress the pelvis from both sides. Gently press the iliac crests. Inspect the extremities. Assess distal circulation and motor and sensory function. And log roll the patient and inspect the back. Next, measuring blood pressure by auscultation. Follow standard precautions. Check for a dialysis fistula, central line, previous mastectomy, and injury to the arm. If any are present, use the brachial artery on the other arm. Apply the cuff snugly. The lower border of the cuff should be about 1 inch above the antecubital space. Support the exposed arm at the level of the heart. Palpate the brachial artery. Place the stethoscope over the brachial artery and grasp the ball pump and turn valve. Close the valve and pump to 30 millimeters mercury above the point at which you stop hearing pulse sounds. Note the systolic and diastolic pressures as you let the air escape slowly. Open the valve and quickly release the remaining air. Next, measuring blood pressure by palpitation. Follow standard precautions. Secure the appropriately sized cuff around the patient's arm. With your non-dominant hand, palpate the patient's radial pulse on the same arm as the cuff. Once you have located it, do not move your fingertips until you've completed taking the blood pressure. While holding the ball pump in your other hand, close the turn valve and slowly inflate the cuff until the pulse disappears, and then continue to inflate another 30 millimeters mercury. As the cuff inflates, you will no longer feel the pulse under your fingertips. Open the turn valve so that air escapes slowly from the cuff, and carefully observe the gauge. When you can again feel the radial pulse under your fingertips, note the reading on the gauge as the patient's systolic blood pressure. Last, open up the turn valve further and completely deflate the cuff. Document your findings, including the time, and note that the pressure was taken by palpation. Assessing neurovascular status. Palpate the radial pulse in the upper extremity. Palpate the posterior tibial and dorsalis pedis pulses in the lower extremity. Assess capillary refill by blanching a fingernail or toenail. Assess sensation on the flesh near the tip of the index finger and thumb, as well as the little finger. On the foot, first check sensation on the flesh near the tip of the big toe. Also check sensation on the side of the foot. For an upper extremity injury, evaluate motor function by asking the patient to open his hand. Perform motor tests only if the hand or foot is not injured. Stop a test if it causes pain. Also ask the patient to make a fist. For a lower extremity injury, ask the patient to flex the foot and toes. Ask the patient to push down on the gas. Also have the patient extend the foot and ankle and pull the toes toward the nose. That's assessing neurovascular status. Last, assess blood glucose levels. Take standard precautions. Clean the site, like the finger, with an antiseptic. Puncture the site with a lancet needle. Dispose of the needle in a sharps container. Obtain a drop of blood on the test strip. Insert the test strip into the glucometer and activate the device per manufacturer's instructions. Place a bandage over the puncture site. That's it.